So even last time also we dealt with inner ear, and even this time also we are dealing with inner ear disease. So today the topic is Meniere's disease. The other name for it is endolymphatic hydrops. Now, okay, endolymphatic hydrops or Meniere's disease, it was discovered by Prosper Meniere in 1861. So what he discovered was, he discovered a syndrome which is characterized by deafness, tinnitus, and episodic vertigo. So he linked this condition to a disorder of the inner ear. As you know, the balance is dealt by inner ear. And again in 1938, Halpike and his Crane's underlying pathology of the Meniere disease as being endolymphatic hydrops, but the precise etiology was still not known exactly. So even though Halpike and Kahns, they found out that Meniere's disease is due to endolymphatic hydrops, that is the imbalance between the absorption and production of the endolymph, but they did not know exactly what was the cause. Now, if we go back to our anatomy again, okay, and you do remember the fluid, perilymph and endolymph. So what is perilymph? Perilymph, it is located in the scala vestibuli, scala tympani, and they have a similar composition to cerebrospinal fluid. They are high in sodium and low in potassium. Whereas endolymph, this is located in the scala media, and they have similar composition to intracranial fluid, and it has just the opposite, low sodium and high potassium. And where are they produced? They are produced in stria vascularis. So as you know about all this, and the membranous labyrinth, they separate the compartments. Now we go to pathophysiology. It says that this condition occurs either due to overproduction, increased production of the endolymph, or due to faulty absorption of the endolymph. As we said, it is produced by stria vascularis, whereas it is absorbed by Kilivarsa. Absorbed. Thacha? Does anyone know? Tatsena? Endolymphatic sac. So the problem here could be either increased production or decreased absorption, or sometimes they can be both. And endolymphatic hydrops, what does it do? It leads to distortion of the membranous labyrinth. So what happens? The resinous membrane, they can be seen bulging into the scala vestibuli. Okay, if you look and dissect and look at it, and when it bulges, there can be micro ruptures. So what does it do? When there is a micro rupture, this can lead to mixture of the endolymph with that of the perilymph, and they can lead to episodic attack of vertigo. But it slowly resolves when the defect, the tear, starts healing. So this is the pathophysiology. As you can see, the normal labyrinth and the dilated membranous labyrinth, as you can see in the pictures. Now, etiology. Exact etiology is not known, but there are various theories behind. So one theory says there's a defective absorption of the endolymph. So why does it occur? Either there can be some anatomical problem, that is obstruction of the endolymphatic duct or sac. There can be ischemia of the endolymphatic sac, so the absorption rate is not in balance. Or there can be, so what happens? So this leads to distension of the membranous labyrinth. Like we said, there's a rupture in the micro rupture in the resinous membrane, mixing, again leading to episodic vertigo. Now, the other theory says there's a vasomotor disturbance. So what happens here? There's a sympathetic overactivity that leads to spasm of the internal auditory arteries and its branches that interferes with the function of the cochlear and vestibular neuroepithelium, leading to vertigo and deafness. Another problem is when there's a decreased blood supply to stria vascularis, it leads to increased permeability. There's a transduction of the fluid, leading to again increased production of the endolymph. And then the other theory is allergy, and it has been seen it could be due to food or inhalant. It has been seen around 50% of the patient with Meniere's disease, they have allergy. Another is sodium and water retention. This could also lead to endolymphatic hydropes. Even hypothyroidism does lead to endolymphatic hydropes, and there are around 3% patients have this hypothyroidism. And the autoimmune and viral cause are also there. So these are the various theories, or let's say etiology, leading to lymphatic hydropes or Meniere's disease. Now, if you look at the clinical feature, the age ranges from 35 to 60 years of age, more seen in the male patient, and it is a unilateral disease in the early stage, but may involve the other ear after several years. Now, what is the cardinal symptoms of Meniere's disease? So these things need to be there for you to diagnose that this patient has Meniere's disease. So what is it? There's a periodic episode of rotatory vertigo or dizziness. There's fluctuating, progressive, low-frequency hearing loss. And there's ringing of the ear, which is known as tinnitus. And the patient feels fullness or pressure over his or her ears. So these are the cardinal features that the patient will have. Now, when you need to diagnose, detailed history is a must. So you have to take the history thoroughly, which is the most important part, okay, in order to make the diagnosis. Then you need to look at the symptoms, and then if there's a hearing loss, tinnitus, and vertigo, all three components present, then this you can go on to your diagnosis. Now, when you examine this patient, so what happens here? It depends on the phase of the disease, okay? So when you examine, sometimes you may not even find anything, even if the patient has got Meniere's disease, but when the patient comes with a acute attack, then the patient is really not well. He has a severe vertigo associated with tinnitus, hearing loss, and pressure or fullness over the ears. But when patient does not have this attack, and when you see the patient, then the patient may be completely normal, okay, and symptom-free. So does not even complain anything, and you may not even find in the early stage of the disease. So, as you see the vitals, you can record, and you see the increase in blood pressure, pulse, okay, and respiration, and they look very ill, pale. But if you check the nystagmus, you will see spontaneous nystagmus directed towards the affected ear, as this is initially unilateral. So whichever side is affected, it will be directed towards the affected ear, typically during an acute attack. Now, so when you do an otoscopic examination, you would see the drum absolutely normal. So there's no findings for Meniere's disease. The drums are normal. And when you do a tuning fork test, the Rini will be positive. That is, air conduction is better than the bone. And the Weber is lateralized to the affected, away from the affected ear towards the healthy ear. So this patient will have sensory neural hearing loss. So Rini will be air conduction better, Weber lateralized away from the affected to the healthy side, and ABC is absolute bone conduction is decreased. Now, you also need to do a complete neurological evaluation, okay, along with the ENT examination to rule out other conditions. And if you do a Romberg test, this patient is very not stable, and when they close their eyes, they are even more, the condition even worsens more. Now comes those were the examination. Now comes the investigation. So the first thing you investigate is do a pure tone audiometry. So what do you see? There's a low frequency sensory neural hearing loss, okay, that you can see. This is the audiogram, and you can see in the initial stage, these are the low frequencies. So you see the up sloping curve. So there's a low frequency hearing loss. As the disease progresses, there's a hearing loss in the higher frequency. So instead of upsloping, the curve becomes somewhat flattened. And as the disease goes on for several years, then you see a downsloping curve. So, but in the exam, if they have to give, they would give you the low frequency sensory neural hearing loss. Okay, this is like we discussed, Carhart notch is the typical findings in the audiogram of a patient with otosclerosis. Here in Meniere's disease, you would see low frequency upsloping curve in case of Meniere's disease. Now, speech audiometry, it is about 55 to 85% between attack, impaired during the attack, acute attack. And special audiometry tests are also done. This indicates the cochlear nature of the disease and thus helps to differentiate us from that of the retrocochlear lesions. These will be explained and you will understand better after the audiology class. So when the audiology class, I think there are 4 audiology classes, and he will teach you all this in detail. And he will also tell you this happens in Meniere's, this happens in otosclerosis, so you don't need to be so lost now. And he is a better person to explain. So, but what are the investigation of Meniere's disease is a very common question, right? Iraqnini questions, though, so please, you should know and write accordingly. So recruitment test is positive, short SI test is better than 70%. So these are the things. And there's a table in your book. It shows the difference between the cochlear lesion and the retrocochlear. Retrocochlear lesion is acoustic neuroma. Okay, cochlear is this Meniere's. So you have to know this, okay, table. So please go and read this, and this can be explained in detail by the audiologist later. So Oilekolagi, you don't need to bother, I mean, it will be only asked to you if in any exams after the audiology class will be taught to you. So this is in your book. Now, another investigation that you can do is electrocochleography. This measures the ratio of summating potential and the nerve action potential in response to auditory stimuli. And in case of Meniere's disease, the ratio is greater than 35%. And this is the most accurate investigation when the Meniere's is active. So this is the action, the electrocochleography, and you can see the normal and the diseased findings. Calorie test is another important investigation. So what do you see here? You see canal paresis on the affected side. And glycerol test can also be done in the OPD when the patient comes in order to diagnose. So what does it happen here? You give the patient to drink Nitroglycerin 1.5 ml per kg is given orally, and patient is asked to wait for at least 2 hours, and then again the audiogram is repeated, and what you do see, you see there's an improvement of the hearing and discrimination score. Now you can even do imaging like MRI and CT scan. MRI is done to rule out any abnormal anatomy or any mass or lesions are there. Whereas CT scan, it reveals if there's any dehiscence in the superior semicircular canal, or if there's any anatomical variation in the bony structure of the cochlea and vestibular duct. There are other variant of Meniere disease. What are those? They are cochlear hydrops, vestibular hydrops, drop attack or Tumarkin crisis, or Lermois syndrome. So what is a cochlear hydrops? Here, there's a cochlear symptoms and sign of Meniere disease are present, but vertigo is absent. It appears after several years. So what happens? This happens due to the block at the level of the ductus reunions, leading to increased endolymphatic pressure to the cochlea only. Whereas vestibular hydrops, there's a typical attack of episodic vertigo, while cochlear function remains normal. With time, that a typical picture of Meniere's disease will develop in a recurrent vestibulopathy. Drop attack or Tumarkin crisis. There's a sudden drop attack without loss of consciousness, and there's a feeling of being pushed to the ground. Okay, this is drop attack, but the patient does not have vertigo or fluctuation in hearing loss. Lermois syndrome, as you can say, this is symptoms in reverse order. What happens here? Initially, there's a progressive deterioration of the hearing followed by attack of vertigo. Whereas in Meniere's, the patient would have vertigo first. Okay, then the hearing loss comes. When the patient comes initially, when the disease is in the early stage, the patient comes, you do an audiogram, you would see the low frequency hearing loss. After the treatment, after some interval, you call the patient and then you do an audiogram, then you would see the hearing is improved. That is why it is called fluctuating hearing loss in case of Meniere's disease. But as the disease progresses with several years, then obviously it will not come back to normal. Then you would see those different curves, upsloping, flat, and downsloping curve. The other differential diagnosis, if asked, they are perilimb fistula, recurrent labyrinthitis, even otosclerosis, okay, some congenital ear malformation, neurosyphilis, encephalitis, meningitis. These are the other differential diagnoses. There's this American Audiology and Head and Neck has given this diagnosis for Meniere's disease. This is in your book too, but I don't think they'll ask you this, but you should know the definition of the Meniere's disease. But you can just go through this. Now, very, very important part is the treatment. So this is asked in the past several times, so you should know treatment of Meniere's disease properly. So first, it is divided into first one into general measures. So what are those? You need to reassure the patient, because patient is very once the person has vertigo, they are very scared. They don't know when the vertigo will come, and the experience is really bad. So they need to be reassured about and explained about the disease. So reassurance is a must. And you need to, if the patient smokes, then you need to ask the patient to stop smoking. The salt restriction has to be there. Okay, only 1.5 grams sodium per day is advised. You need to avoid excessive intake of water, excessive intake of coffee, tea, or alcohol. And even the patient needs to change their lifestyle. And then they need to avoid activities where they require body balance. So they should not be going for adventures and all that. Now, when there's divided into management of acute attack and chronic attack. So under the heading of acute attack, again, reassurance, the patient needs to rest, okay, and there are vestibular sedatives, and commonly we give propropyrazine, even cenarazine is also given, okay, promethazine, dimenhydrinate, even sometimes you need to even give diazepam in order the patient to calm down. So these are the vestibular sedatives you can give orally if it's not very patient is not in a very bad condition, or you can even admit and give, okay, in intravenously or intramuscularly. And vasodilators, these are the inhalation of carbogen, or histamine drip can also be given. And even steroid injection are helpful because these are potent anti-inflammatory agent. So it reduces the interlymphatic pressure, and then it reverses or it decreases the symptoms of what the Meniere's disease patient has. Now, again, when you have to manage a patient in a chronic phase, what do you do? Again, give them vestibular sedative, but this has to be given for a longer period of time, okay? You can start off with 5 mg. If not, then you can increase the dose, or if he or she has a very severe attack, then you can start with a higher dose and come down to the lower dose. Vasodilators are also given. The commonly used are beta histidine. We give 8 to 16 milligram 3 times daily orally for at least 3 to 4 weeks. Diuretics are also given. These are, we can even give potassium sparing diuretics, hydrochlorothiazide or furosemide, or sometimes even acetazolamide can also be given. And depending on uh, elimination of the allergen, if the allergy is the cause, and hormones. In case of hypothyroidism, you may have to give thyroxine supplement to the patient. So these things needs to be done. Now, there's another treatment which is intratympanic gentamicin therapy. This is also known as chemical labyrinthectomy. So initially, Flowers, Shipnet, they had established an aminoglycoside therapy is helpful in case of Meniere's disease. So they tried with streptomycin, and the vertigo was eliminated. I mean, the vertigo disappeared in all cases, but it had a profound side effect of hearing loss in all patients. So this is not used. And now the gentamicin treatment is now preferred. Okay. Gentamicin is preferred because it is more vestibular selective, and even though there is a side effect like it gives you temporary imbalance, nystagmus, it can also give hearing loss or tinnitus, but it is much more safer than the other aminoglycosides. So how do you give? You give daily or bi-weekly injection into the middle ear, and this is absorbed through the round window, and then it leads to destruction of the vestibular labyrinth. This injection controls vertigo of about 60 to 80% patients, and hearing loss sometimes may be seen. It might be sometimes severe or sometimes profound, have also been reported in only 4 to 30%. But people have benefited from this procedure. You can even put in a gel foam placement can be put, or micro-wick can also be put with gentamicin. Now comes the surgical procedure. If the medical does not help, then surgery may be indicated. So there are various types of surgery. One is conservative, So under the heading of conservative procedures, you can decompress the endolymphatic sac. You can have a shunt operation and drain, okay? There can be sacculotomy, that is puncturing the saccule with a needle through the stapes foot plate. Another is section of the vestibular nerve, is another conservative surgery that you can do in case of Meniere's disease. Now there are destructive procedures too. What are they? There's only one, that is labyrinthectomy. Here what happens? It destroys totally the cochlear and vestibular function, and these are only used when the cochlear function is not serviceable. Yeah. So you do it when the patient has a dead ear. So what do? What happens when you do labyrinthectomy? The membranous labyrinth is completely destroyed, okay, through the lateral semicircular canal. By transmastoid approach, you can do this procedure, or through the oval window, through transcanal approach. So you don't need to open up the cranium. There are other approaches, and it does help in more than 95% of the cases, okay. So, and last of all, another treatment is intermittent low pressure pulse therapy, or miniate device therapy. So you can see the device, and this has been approved by FDA in 1999, and treatment can be self-administered. You don't need anybody. You can use it 3 times daily, and each treatment is 3 times 1 minute cycle, and it applies intermittent alternating pressure of 0 to 20 centimeter of water. So in order to give this pressure, you need to put in a grommet, okay, and through this tympanostomy tube, this pressure can be applied. So first you need to put in a tube, and the pressure wave passes through the perilymph, and it can cause a reduction in the endolymphatic pressure. But this treatment is only considered to those patients who have failed medical treatment, and the second option would be surgical. Before surgical option is taken, you can try this minute device therapy, giving an intermittent low pressure pulse. So this can also help patient, so they don't need to undergo those surgeries, because sometimes even after they undergo those surgeries, patient may not, some patients do not get cured totally. So these are the conservative treatment and surgical treatment and intratympanic gentamicin injections and the intermittent low pressure pulse therapy. So this question of treatment of Meniere's disease is very, very important. It has come several times, so make a star in your book, and please know this properly, okay? Even if you mention all the surgery and write just one line, at least you will score a good, grades, rather than leaving behind half. So please, this is important. And I guess this is all. So Meniere's disease is important, autosclerosis is important. You would definitely get some questions from these, either in your short notes or in your MCQs, Viva, okay? So every angle, these diseases are important, exam point of view. So please go back and study, and whatever you may have difficulty not understanding the audiology section,